Me here today. So I'm going to talk about the impact of Ebola on health systems, vaccination programs and population health. So I think we're all familiar with the Ebola outbreak. I won't labour it other than to recap that the outbreak began in rural Guinea in December 2013, rumbled on for a few months, and then once it got into urban centres, it became widespread and intense transmission. And the peak of the outbreak really occurred between August to December 2014. So to understand the impact on the health system, we first need to have an appreciation of what the health system looks like. So I've done assessments in three rural districts in Sierra Leone across the three provinces, and I just wanted to give you a snapshot really of what the health system looks like. So this health facility, for example, serves 7,000 people. And the condition of health facilities in general was very poor. I got somewhat obsessed with delivery beds, which you can see here. And the conditions are very cramped and poor. Outside of the major cities, electricity supply is non-existent, so obviously that makes things very difficult at night time with deliveries. This storeroom, I remember being 32 degrees. There's a real profound lack of essential medicines. So aside from anti-malarials and amoxicillin, there's really nothing else available routinely. The lady on the bottom left, she couldn't speak the same language as a catchment population of 7,000. The chap on the motorbike has had 3 years of basic training. Yet he's the man in charge of a health facility serving 26,000 people. The picture to the right looks quite an attractive view until you realise that's the water source for the health facility. And in fact, a third of the health facilities that we did inspections on were using those kind of water sources. Secondary care, so again, similarly depressing. These are district hospitals, Moyamba district, Koinadugu, Tonkalili look like this as well, with rusty diesel generators supplying power, one of the districts for 2 hours per day, 3 days a week. So if you're needing illumination for major surgery, it's a problem. No piped oxygen in any of the district hospitals, laboratory facilities, so you can do a hemoglobin, a white cell count and microscopy, but not much else. No neonatal incubators, no maternal ultrasound, that's typical. And even if you can get to the hospitals, the chances are you as a patient won't be able to afford the care provided. Which brings me on to access. So this was a picture sign in Koinadugu district encouraging people to use health facilities for delivery, but in that district you may be up to 40 kilometres away from a health facility. We were there in the dry season, and during that time we still had to cross rivers. That sort of terrain is really not navigable for many months of the year during the rains. And whilst we had the luxury of helicopters at that time, the reality for most people is at the bottom right. So in terms of vaccination, well, each health facility is supposed to have an outreach plan. This is an example, so you have 11 villages here. The ideal would be that the healthcare worker would travel to those villages, given the problems with access, and then vaccinate eligible people. However, mostly we need to make health facilities make a central sort of meeting point and then encourage people to come and get vaccinated. However, even before Ebola, you can see that vaccinations performed by outreach activities such as that are very much suboptimal. So that's the case for many districts, well below the target. Ebola came. So what impact on that kind of health system? Well, the first thing clearly is that healthcare workers are in the front line and were likely to be exposed to Ebola clearly. WHO estimated that healthcare workers were between 21 and 32 times more likely to become infected than the general population. There were about 881 confirmed reported infections amongst healthcare workers and over 500 deaths in the three countries. So that is approximately 6.9, 8.1, 1.5% of the workforce in Sierra Leone, Liberia and Guinea respectively. So obviously there are long-term implications. The combined, so I estimated the combined ratio of doctors, nurses and midwives remaining was 1.8 in Sierra Leone, 2.5 in Liberia and 4.5 per 10,000 in Guinea. That's substantially below the 23 per 10,000 threshold, which is essential for the delivering Millennium Development Goals, and well below the 123 per 10,000 in the UK, similar for France. As you might imagine, being an isolated healthcare worker without personal protective equipment, many understandably abandoned their posts, at least initially, faced with initial overwhelming demand, which and concern about healthcare worker safety plus demand led to closure of hospitals, so 3 largest hospitals in Monrovia in Liberia, but also hospital closures in Sierra Leone and Guinea. Depending on the time and who's looking, between 4 and 62% of primary healthcare facilities were closed at one point. So Liberia reported 62%, and Sierra Leone, when the ministry did its own survey, said 4% of health facilities were closed. But regardless, the health system didn't entirely collapse, but what you did see was a change in healthcare worker behaviour. So for example, inpatient surgical procedures declined by 70% in Sierra Leone nationally by the end of 2014. So we saw a change in the way that healthcare workers were undertaking, say, risk procedures. This is just an example. We also saw resource diversion. So this is your typical district health management team structure. And in the districts I went to, the health system leaders were diverted to the Ebola response. So the district Ebola response is DIRC. So the leadership of the health system had to effectively abdicate that responsibility to deal with the here and now of Ebola, and therefore were unable to give the governance to the health system that it required. Another example, Moyamba district, 400,000 people. This is their health workforce pre-Ebola. You notice there's 2 practicing doctors there. There was a change post-Ebola. Clearly some died, some were embroiled in the Ebola response. But I think the most important thing is the bottom row there. So you had 1,000 volunteer community health workers. These are the ones that go into the communities, encourage people to get vaccinated. And largely they went. So you had some recruited by the Ebola response, and many just stopped working. Why would you? You're not getting paid, facing risks. So in both districts I went to, the district medical officers had no idea, but approximated that less than half were still working. Then you had the social impact of Ebola, which I'll just briefly touch on. You can imagine that these 3 countries were recently recovering from civil conflicts, civil war, and suddenly you have uniforms on the street, and you have curfews, Ebola checkpoints, access to healthcare clearly wasn't good to begin with. This didn't help. And it's quite intimidating, actually, everywhere you go to be facing these infrared thermometers. You know that if that makes the wrong sound, then you're off to an Ebola treatment centre. And bear in mind, obviously, malaria is endemic, infectious disease, incredibly common. I think this picture really demonstrates quite well how it might feel to be in a rural village, and suddenly you're faced with people coming in spacesuits, removing the sick, who you probably are not going to see again, removing bodies without opportunity to bury them in a culturally appropriate manner. And that created a great deal of upset, angst, as you can imagine. That translated into violence. There was rioting in Liberia. Healthcare workers were attacked in Guinea. But I think more profoundly, it led to this real lack of trust or loss of trust in authority and the health system. So these are just quotes from what people told me, but you can find many such examples such as this. So healthcare workers were blamed for creating, and the international community for creating Ebola, and healthcare worker for spreading it. And this is a theme that was repeated many times. So needles injecting Ebola, which is clearly of relevance for vaccination programs. Loss of trust in the health system. I think the greatest impact was really on health system utilisation. So it's very obvious walking around the district hospitals that at a time where you perceive the need would be very great, the health facilities were empty. I think this picture really reflects the situation. I just give this as an example. These are headquarter health facilities and chiefdoms. There was a real Ebola gradient. In the most affected chiefdoms, there was quite dramatic reductions in health facility utilisation, and 75% I think here in those 4 months compared to the year before, and less so in this least affected chiefdom. This is just a district hospital with a 44% reduction in maternity admissions, so for delivery. This really concerned me because it's illegal in Sierra Leone to give birth in the community, and there was no other recording of where these births were taking place. Likewise, paediatric admissions, so 75% reduction in this district hospital. And where there was national data, it very much reflected this. So outpatient consultations in Sierra Leone had halved by the end of the year. Similar story in Liberia, health facility utilisation end of 2014, 59% lower. Same in Guinea, and with hospital admissions. Pregnant women and children were disproportionately affected, and again there was an Ebola gradient, so in the most affected areas up to 81%, a reduction in assisted delivery in Guinea. So how did Ebola impact on population health? Well, I haven't got a huge amount of time to go over this, but there was a very wide-ranging impact. So you had the health system impact, which is down to reduced provision, governance, etc. You had this complex social impact, which is not just breakdown in trust, it's also a breakdown in community and social cohesion. And then you had a very big economic impact, which impacted on households, so reduced income, reduced jobs. Then to compound that, you had reduced access to healthcare, reduced health system utilisation, and therefore there was an overall impact on morbidity and mortality. And that's in addition to the direct impact of the Ebola virus disease itself. So mortality data actually is quite sparse. This is just recording of deaths in Moyamba district, where I looked at burial data compared to the years before. Clearly, during Ebola, recording was better. So I just put this as an illustration that there were far more deaths recorded than there had been before. And the vast majority were in young people. So 42% of these deaths were in children under 5. 27% of the deaths were in children aged under 1 year. So vaccination programs. Well, I think I've demonstrated how they might have been affected already to some extent. But on top of that, mass gatherings were banned. So therefore, mass vaccination and vaccination campaigns were suspended in all 3 countries. Certainly, community vaccination and outreach was curtailed, not encouraged over safety concerns. And I've already shown you reduced provision, and clearly less people wanted to get vaccinated. There's very little coverage data. This is just one district where I looked at the numbers, and since the Ebola outbreak reached the district in June of that year, 2014, there was obviously a big reduction. Where there is national data, substantial declines were reported. I'm not sure how much you can always trust, but the theme was the same across all three countries. And there are ongoing challenges which I just wanted to touch on. Some are a legacy of Ebola, some are long-standing, exacerbated by Ebola. This is one thing that really was a bit of a bugbear to me, that you'll see this in many districts in Sierra Leone, that coverage is reported as well over 100%. And people use the 2006 census, which is wildly inaccurate. When challenged, someone produced another population estimate, and I needed to demonstrate that even whichever population estimate they're using, it's inaccurate. Why is that important? Well, firstly, ministry are falsely reassured by coverage data, and secondly, the problem with the census data is that the supply of vaccines is linked to it. So if you're underestimating your population, then you get too few vaccines. And it's very difficult to plan, therefore. Actual coverage, well, this is from 2013 Demographic and Health Survey, 12 months to 23 months. So this is probably more reflective pre-Ebola of actual coverage of vaccination. Now, well, we've just done a survey in Sierra Leone, so we'll see. In terms of, there's also a big problem with distribution. So none of the districts had dedicated vehicles to transport vaccines, fridges, supplies. This is the one that I was shown was previously used, but not in a great state. Cold chain, well, 40 to 50% of health facilities in the three districts had working fridges. And there was a complete absence of cool boxes, so for outreach activities. So the cold chain clearly has broken down. I just want us just to think about, to imagine that we are this healthcare worker. She's the only healthcare worker at this health post providing care for 3,000. In order to provide vaccination at villages, she'd need to abandon that post for a day. She doesn't have any transport to get to the village. And importantly, there's a big financial disincentive for her because she needs to go and collect the vaccines from the capital of the district at her own expense. So she needs to pay for that transport and pay to go to any villages if she's using transport. There were certainly safety concerns during Ebola, and the work is physically demanding getting to these villages. As I can attest, this is 2 weeks ago. It was sweaty. But there are some encouraging signs. So there's clearly a lot of work to do rebuilding trust. But if you provide vaccination, people will come, and provide it free of charge, people will come. So that was encouraging. So in conclusion, I hope I've imparted to you that the impact of the Ebola outbreak on an already poorly functioning health system was severe. There was a really marked loss of trust between the health system and the community, which led to reductions in healthcare utilisation. We've seen that vaccination programs were compromised and the uptake fell substantially, and that support is required for health system rebuilding and to strengthen vaccination programs. These were just recommendations I wrote a year and a half ago, which I think still are valid. Mass vaccination has taken place in May and June for measles and polio with reasonable reach. There's still a real need to engage with communities, to encourage people to go back to health facilities and to take up vaccination. We really need to address these disincentives for healthcare workers to conduct outreach, resources to ensure the cold chain could be as simple as just having more cold boxes, mobilise an unused community workforce to deliver vaccines, not just to rely on the one healthcare worker, and support from ministry and advocating for a revised population estimate is required. So thank you very much for the opportunity to talk to you and for your attention.